Thank you so much, Jean. So our next speaker is Toby Bourisseau. She is a child adolescent psychiatric clinical nurse specialist and APN clinical lead at University Hospitals. She's almost 20 years of experience in psychiatry and mental health, and she holds her MSN from Kent State University and her undergraduate from Case Western University. She was a member of the advisory board to develop a child adolescent psych CNS program at Kent State and created best practice alert for monitoring of atypical antipsychotic UCS. She also provided support of victims at Hurricane Katrina as a member of the Substance Abuse Mental Health Services Education Team. Please welcome Toby.
Thank you for coming today, and let me see, what do I show? Okay, slide. I'm not tech savvy, and I speak a lot in front of groups, but I love teaching. So I just want to say thank you all for coming today, because I think that there's a lot of health providers in pediatrics and in general. We really need better ability in primary care and across the board to be able to identify mental health treatment strategies, depression, anxiety in kids, and have good intervention early on. So that's what I want to talk about today. I really want to give you guys good strategies and with you. So these are really big topics and probably separate talks, but I condensed a lot of information to one talk, and so it's a lot to go through, and I'm hoping we have enough time. And, but to give you guys some good stuff to take to you. So, all right, a little vignette. This is probably something typical you might see in a well visit or just practice, or something that comes into someone that might come into my office on a daily basis. So Susie's an old female, comes for her, I put routine physical because I'm sure this can happen quite soon. Has some concerns about her change in behavior past 3 months. Don't really ever know how her mood's going to be. She's crying in her room with no explanation or yelling at them. Doesn't want to play soccer anymore or hang with friends that much. Laying on stomach aches. She's made some comments that nobody likes her, school's so hard, spending a lot of time sleeping, not eating well. She's never talked about wanting to die, and said to mom that no one understands, and she just hides under her covers. Her PHQ-9 score is 11. Is everyone a PHQ-9? So I use that routine in my practice because it's more of a screening tool in general primary care, and oftentimes by the time it comes to psychiatry, they're pretty well identified, as having significant symptoms. So we questions what they might do. A patient like this that they've seen. Yeah. So this is a good starting place to kind of decide what are we going to do, and how do we go for treating this, whether it's kind of a referral to therapy, or is it something that we want to dig more in and decide if medicine would be appropriate, or referral to psychiatry. The issue is that's probably going to be a wait, as everybody knows, because it's hard to get in. So, this is a great place to figure out if you want to do some intervention. And, depression is pretty significant. It has a significant impact on children and adolescents. There is long-term consequences. So know what happens, right? Kids have long-term disruption in their emotional and cognitive skills. It impacts family interaction. can lead to substance abuse, legal problems. The suicide rate is pretty significant in all groups of doesn't matter if you're an African American, it's increasing the cause of death. So we look at like different age groups and really identify symptoms of, because it's different from adults. Kids aren't mini adults, and they don't have good verbal skills. They know how to express themselves without much more externalized and behavioral. Really little kids is really important to look at the context and what's going on in their life. So the thought is really probably it's not an organic depression, but there might be some abuse or neglect going on. There could be parental discord. There could be things in their life or family that could be causing this change in behavior. They have a lot of crying, anxiety, physical complaints, oppositional behaviors. Into the elementary age group, same kind. They might have new onset outbursts. So a lot of parents come in and say that it's like defined as oppositional behaviors, tantrums. A lot of kids also have anxiety. No understands. I hate you. My parents hate me. These kids can also have some, auditory hallucinations, saying like, the voice is telling me that I'm no good, or the voice tells me I should hurt myself. And older, age 12, kids start to present a little bit more like adults with depression. They'll say like, I thought they were just going through some teenage angst. They're all in the room, but yeah, I thought that was kind of typical because, their TV's in there and they got everything they need. But they might like stop doing hygiene, they kind of down in their grades, stop doing sports or other interests, stop eating well, they might be sleeping more, maybe they start using marijuana or drinking. They also start with some more concerning self-harm behaviors, really putting things out on social media that might be depressing. So we want to look at a clear change from their daily functioning and look at, this idea of anhedonia, the really lack of ability to find joy, versus is this just a kid who's demoralized from things going in their life? And teens in that subgroup, words to describe how they're feeling. So a lot of times, and this goes with anxiety too, kids use the word depression. They use things like, I'm hopeless, my mood is sucky, I can't focus, that's a big one. I'm just miserable, nobody gets it, I don't want to be here anymore. So with those kind of things, then I just dig deeper. But when we just kind of like use the textbook, do you have this, this, and this, a lot of kids, they don't really identify with that, the typical criteria. So we have to use language. And that's what I'm going to ask the terms, use the terms that they use. So ask always about other things going on. Have they been bullied? What family stress is going on? Are there any, is there any legal trouble, or is there any legal issues in the family? Are substances? Or they ask about gender, sexuality, kids that are having, gender identity, or maybe hiding their gender, really are struggling with anxiety. That can be a reason maybe why they're avoiding school, feeling bad, maybe if they're having gender dysphoria. So that's a topic that is certainly something to bring up, and they don't even want their parents to know. Cause a lot of depression and anxiety. Again, I put a lot on electronic use because a lot of times electronics are in their room. Parents take them. Kids are texting. They're on Snapchat, Instagram. I'm in particular is when maybe a kid is stressed and seeing I post or put something out there, and then next thing you know, the parents get a phone call from, the friend concerned parent about what they're doing, and they have to be there. want to look at, medical illnesses that might be going on. I dental surgery, so it's hard to talk. A lot of fun to ask about family history of, you might have hypothyroid, low vitamin D, which we have here in Cleveland, but a lot of kids are super deficient, and we had to have kids take amounts of vitamin D for their fatigue or motivation or mood. A lot of kids that are on stimulants, and kind of looks like they're dull, blah, just really down. And so sometimes that looks like depression, and it's an effect of the medicine. Other things, again, risk factors for, is this, there's concern of, that's a whole other talk, but we also look for any signs that this could be more than just a depressive disorder. Care, I found a toolkit because, again, like I said, by the time they come to me, allowing, it's kind of beyond simple screening, so I think primary care is a good area where you can do some kind of quick screening that gives, a good snapshot of some symptoms. So website from primary care toolkit for a lot of good, valid, reliable screening tools. So they're all right there. And with treatment, this study talks about, the different stages of treatment. So briefly going through it, we know that placebo response in children is pretty high, as high as 50%. So you really think, where are they on the spectrum of severity for the depression symptoms? Have they ever had psychotherapy? And is that something that we can do as a first intervention? And it'll fit that. So I think especially important to think about for the younger kids. With psychotherapy, I want to move into considering medication. So this study supports, trying one medicine first with an SSRI, and two, if they failed that, we switch to another one. Then we talk switching to a class, augmenting, and then time for reassessing, thinking about the diagnosis. But once you're stable, the key is we really want to continue treatment for 9 to 12 months, because if the kid or the teen has had a depressive episode, they're 50% more likely 5 years out to have another depressive episode. So a lot of kids will start feeling better, right? Like adults, they stop taking medicine. Maybe parents have put it in their control to take their medicine. So I didn't know they stopped taking the medicine. All of a sudden, things are not good again. So I, at the start of treatment, kind of walk them through the plan. The first month is kind of initiation phase. We're getting you medicine, the right dose. We want to keep that going for a good 9 to 12 months before we talk about taking you off medicine. So tell them, it doesn't have to be forever, but we do want you in a stable place before we talk about taking the medicine away. For me, I like to do it during the lower stress time, which for most kids or teens is during the summer. So that's a time when I would be more likely to take away medicine. When I tell parents about what medications we want to try, things that have an FDA approval for depression in kids and teens are Prozac and Lexapro. In the book, and those are the two that you'd want to start with. Things aren't all because you look at side effects and patient preference. A lot of parents kind of like gawk when I talk about Prozac because they've heard things or on the internet. So I really go over the research with them a lot, and sometimes I'll even pull up this one study. I mean, it's kind of a large study, the TAD study, that shows that a combination of Prozac and cognitive behavioral therapy is more effective in treating, again, moderate and severe depression. And so know is, again, by 36 weeks, everything kind of evens out, but for kids that have more significant symptoms, medicine accelerates the response. And obviously, if you have a therapist involved, maybe not obviously, but it enhances the safety of the care because they're seeing someone more frequently. So I'll give parents the data, and I help them understand that, you know, these are the medicines, we have research and support behind them, and that's how I explain to parents. And then, you know, when kids, a lot of kids are resistant or fail a first medicine, so then we think, well, what do you do now? So again, if we try another SSRI and that one fails, well, then we may move to another class. So this study is another really well-known study looking at, okay, well, someone failed an SSRI, and so we want to switch, and we know, like, there's a group of kids are treatment resistant. So what this study showed is that when they switched, basically, the faster time that the fast time to remit, the higher likely to get in remission longer out. But kids can still be treatment resistant and they can still relapse. So what we'll do is have more aggressive treatment early on because that is just a better response in the long term. So we just start kids on a low dose of medicine and leave it there forever. We do get them up to the right dose and like between so that we can see a response, and not having good response, switch them to a different medicine. We may get them out of a depressive episode because the longer they stay in it, the worse it is. So these that are commonly used and SNRIs. So I just put the range of doses. So in general, with younger kids and adolescents too, the phrase is start low and go slow. They're definitely more susceptible to side effects and activation. You know, you want to start low. And for me, I do, you know, every 2 weeks is how I kind of bump the dose if someone's having some response, and then monitor side effects that way. Medicines of the SSRIs that are used would be Bourisseau and Zoloft. Packed it up there, but it's really it higher risk of suicide and pretty significant withdrawal because of the short half-life. So I wouldn't recommend use it, but it is an SSRI that, you know, if kids have failed and some have been put on it. Other medicine not FDA approved, which I said, by the way, a lot of this is off-label. Disclosure that most of what we do is off-label use. Some use well-being, bupropion. Of course, you assess for history of seizure, high blood pressure, and it's really not good in anxiety. The dopamine can kind of exacerbate a lot of kids' anxiety, agitation, nausea. Ritalin sometimes is used for kids who really don't sleep well or are underweight. Again, that would be like a fourth or fifth option. And they really have very no evidence. A lot of the new ones that are for adults have minimal evidence, and the older, the TCAs, which can be used for headaches and some others, have really minimal evidence for depression and more severe side effects for overdose. Yes.
What's the positive?
In 2 weeks is kind of like 6 weeks to really start working. So to get really neurochemical explanation, you know, it's not this simple kind of serotonergic off commercial where it has like, space in between your cells, and like Zoloft helps it blocks the reuptake of serotonin, and so more serotonin goes over here, and then we're happier, right? Well, it's not as simple as that. There's more serotonin involved. So really, it's basically like you have two cells, and the branches on either end have all these, produce the neuromessengers. And depression, like, they're very sparse. There's no buzz. So it takes really 2 weeks to repopulate the buds, the growth, for the neuromessenger to then kind of send the message to the other side and for things to start working. So, but in 2 weeks, we can also see agitation, irritability, hunger, silly, like all that stuff in young kids, stomach upset, like all the side effects I'm going to talk about, kind of 2 weeks is when we see that. So that's the way. But you don't want to, like, put a kid on, 25 of Zoloft and leave them there for 2 months. Because you really want to dose where they need to be. But for you all the time, so I have more comfort doing that. In primary care, I think if you're starting someone on a medicine with the goal being that you refer to psychiatry, I think it's best, you start medicine, like one of the evidence-based medicines at a low dose, and then you could refer them on. Or I think ideally what you want to do is even be able to consult with somebody in psychiatry if you're like, can I do this, can I, or comfortable like doing it yourself, right? There's the dose range that you want to get to, either with effects or they don't do well. But like average dose for Prozac is around 20. Some kids need to go higher. Average dose for Zoloft, 50 to 100. So there's a range, but the reason is because if you go too fast, kids will get side effects. Does that?
I know. Yeah.
How can, so what I do is I have parents either call me and give me an update, or I have them come in. They come in really frequently. So assess what's going on. So for me, again, I'm a subspecialty, but that's feasible in a primary care setting. I describe medicine, that's what I do, but I focus a lot in my sessions on therapy and types of treatment, but beyond the scope of what to talk about today, I focus a lot on exercise, sleep, and imagery, other things that people need to be doing besides taking medicine. But I did want to give you a little information on people might ask you about genetic testing, but the MTHFR gene is part of this genetic testing profile. And so really there's not a whole lot of evidence that it's useful. Then if someone does not, if they don't have the gene, the L-methyl, and supplement with L-methylfolate, and what the research shows is that can help the SSRI to work better, basically. I ask if people are taking supplements or if they see a homeopathic provider, if they're on any natural remedies, because it's really important to know they might interact with medicines, or they might not want to tell us. Especially, it's important to know if someone's taking St. John's wort, that's serotonergic. And like I said, a lot of people recommend vitamin D based on their levels, and some people are on the 50,000 units weekly. This is just some daily. So changing medicines is always kind of a quandary because, you know, in a long time, well, how do you taper and change? And everyone kind of has their own little style of doing it. The best to know is that really the only medicine you can just stop, but even if at a very high dose, you don't just stop that. But, you know, pretty much for Prozac, you know, it has a long half-life. That one you can just stop. Other ones, really you want to do a cross taper, you know, so you want to be low one and starting the other. Because you really want to avoid this discontinuation syndrome, which says finish. So that's a good way to remember kind of symptoms that, you know, anyone, all kids can have when you're cut off. So I love when people come in and I'm thinking of them and say, yeah, I stopped myself like 5 days ago, and it was like, oh, well, and they were on like 200. Did you have any of, you know, this, and this? Well, they made the taper easy for me because I'm not going to go back and put them on it, but I, you know, stress to them. When we're high dose of an SSRI, you do not want to stop it yourself because of all these things, and symptoms can come back. So again, when I start medicine, I talk with them a lot about you have to take your medicine every day. If we're medicine, we will do it slowly and taper off because it's not just pulse and cold turkey. So, okay, little 4-year-old female with her first episode of depression. She's been for 2 months, isolating, grades have been down, moody and angry with her parents. She's lost weight, lacks energy, started talking about what's the point to live, and she cut herself once. She's therapy, has had like 6 plans, doesn't feel it's helping. She's never on medicine. Her family is significant for depression, anxiety on mom's side, and bipolar, and a turtle great uncle. Mom turned Trintellix with good response and asked if her daughter could be prescribed this. So, what would you do? I mean, ask me all the time. You know, I take this, I take these, can you get to my daughter? I take this, and so I mean, I don't know what you guys do. I say, you know, that's a medicine used in adults. There's not any evidence for it in peds. Here's what we use, and sometimes parents get, you know, why won't you do so-and-so's cousin and so-and-so take it? And I say, well, here's the reasons why, and here's what we start with. I draw the side effects, but I do want to point to a few. These are mostly for the first SSRI side effects. As we get up higher on the SSRI doses, they kind of complain, especially adolescents will complain of this, like, kind of dulling, thinking. They just feel like emotionally disconnected, zombie-like, or slowed down. And they'll stop their medicine because of this, because, you know, they don't want to feel that way. So they want to feel less anxious, they want to feel less depressed, but they don't want to feel like they're walking around in a fog. And it really doesn't go away. So I like to help them, but not make them feel like they're just nothing. So, so we'll switch medicine and, you know, try another one. Oftentimes, you know, we can get away with SSRI. Sometimes Cymbalta will do that less. Also, though, I've had kids complain of nausea, sweaty, hot feelings. Effexor, again, I don't use a lot of Effexor, but when I do, I'm same with Cymbalta, watching heart rate and blood pressure, and those need to be tapered. And we already talked, you got to monitor heart rate, high blood pressure issues, and head dizziness. You got to take that one in the morning because it can cause them to have trouble sleeping. Remember on either, but again, we watch that one can cause a lot of weight gain, make kids sleepy. So I focus on activation because it is pretty common, and especially in kids, and I think we're spending time talking about because it's one of the biggest side effects of SSRIs. It's a reason to start low and go slow. So activation usually occurs first few days or up to a few weeks. So it's dose-related. For kids, it happens more with, and kids with ADHD, anxiety, tics, and autism. What happens is kids started on SSRIs who are anxious, like little kids, like 8, and the dose is and then they look like they HD. So they're all of a sudden like silly and wild and hard and impulsive and doing things that are uncharacteristic. Or their is better, but now they're really agitated and angry and doing things that are not characteristic. So other components of activation can be this akathisia. So we know that akathisia happens with medicine. We're not sure why it happens with SSRI medicine, but like pace, shift, like this, need to move, and it can be uncomfortable. Again, it's like mental restlessness. They get disinhibited. So some of this warning related to the antidepressant suicidal ideation. So again, this is another concern parents have when starting an SSRI, and I talked a lot about this warning. So parents are, very fearful. So we go and we talk a lot about, this long time ago, a lot of patients, and that, the risk is low, but it is significant. Obviously, concern that can occur, but again, watch for it closely. It can happen in the first, 2 to 4 weeks, and kids are already having suicide, self-harm, more severe depression are more at risk. Is that the FDA study that was done had a lot of limitations. It did break down the group into subgroups. We really don't know how many of these suicidal ideation occurrences happened in the context of these kids dropping their medicine, which can occur. And there have been, they showed that there was none of this activation or akathisia in the few weeks prior to any suicidal gesture. So there's also this kind of energizing phenomenon with SSRIs where, the vegetative symptoms of depression are improving in the first few weeks, but the kids still might be having these, thoughts of wanting to hurt themselves or fight or die. If they're energized, then they're likely to act on that. So that's why it's really key to be watching them in the first month closely and have them come in more frequently for appointments. What's less common, though, is SSRI-induced mania. So this, is not activation. So mostly if you're seeing something in the first few weeks, it's activation. Long out, a switch. And the key is that there is a clear change in mood and behavior, and there's euphoria and grandiosity that's associated with a switch for activation. And I know there's these different theories about this. So one, cause could be that, there's this genetic predisposition, and then you take the SSRI for a long time, and it's in motion, the bipolar disorder. The Scott hypothesis runs that the SSRI created this new predisposition, or the fact there's no scar, so you take it away, it goes away, it never comes back. Or the course, which is this is going to happen anyway. The SSRI, may have put it into motion earlier, but it wasn't solely because of the SSRI. So after these happen, it's really for families to kind of heads around this. And it's also hard as a provider because treat what we see. You don't have a crystal ball to predict. There are certain signs that indicate maybe a bipolar spectrum, but really, we don't have a way to really predict if it's a in the moment bipolar spectrum. And when you have a kid who has a depressive episode or is anxious, you know, we treat that with SSRI. And so this is very, but it can occur. And I would just say that, you know, we need to be really careful with our evaluation. So, follow that, here's a 15-year-old with a history of depression and anxiety. She was on Prozac with some benefit. When the dose went up to 20, she started having some suicidal thoughts, and she cut herself. She did in the past. Took the medicine and continued in therapy. She was still quite anxious and depressed, and she's not feeling irritable anymore, and she's not hurt herself. And next year for an appointment. So does anyone have any thoughts about what we should do? Because I would say, you know, it's not uncommon to have this happen for me, at least. Anybody care? Yeah, well, so very important, yeah, to assess if there's mania. In terms of, so let's assume we're not concerned about bipolar. This was just an activation. So what I would do, Prozac has a really long half-life, so I would switch to a shorter half-life SSRI, usually the Pro, and I start really, really low. I start as low as 2.5 because I feel like, you know what, it's better to start really low and go up really slow and make sure that they don't get activated again, rather than have them have a negative experience and then not want to take medicine. So I'm quite successful using Lexapro, and sometimes they're just needing to be on 5, 7.5, maybe, but I kind of know that my range, you know, for this girl, she got activated. So, you know, at 10 of Lexapro is equal to Prozac, so I might have my red flag up to not start, you know, obviously I would not start at 10, even 5, you know, I'm much lower. But hey, we start really low, so we may not see a robust response at first, but I'm really looking for side effects. AAP, American Academy of Child and Adolescent Psychiatry, has some really good resources. They have great facts for family. They have some good toolkits for providers. Also, the Center for Suicide Prevention, the Suicide Hotline, a lot of good resources for families, and have these notes to give to families. I'm going to switch over to anxiety now, because I'm not sure that was time, but I love kids. Yeah.
How do you know if you're knowing your attitude? Like, who do you know that, like, oh, that's and like it's not high enough? I feel like I have a sleep and I'm very
yeah.
So often, like I said, they're good. I have, you know.
So yeah, definitely.
Good.
Yeah.
And so I can manage but
yes. So it's my criteria basically, like if they report they're doing, so I look at my original symptoms, right? So like they're less isolative, if they currently reported, if it's, right? I mean, it's not so black or white. But if they're doing better, and again, it's kind of like, depends on the age. So younger kids probably do better on lower doses, right? I don't just up the dose for no reason, but just like the old kids tend to need higher doses. So like elementary school age, probably lower doses are going to work better. Or if it's a more mild case, yeah, lower doses are going to work better. I would see more severe cases and probably have to escalate dose, but I wouldn't just escalate, like keep escalating the dose. I would leave it if they're doing well, and then it's basically like, how if they're stable, then I leave it. Mm-hmm. If they're stable, then I would do them every 3 months. In my practice, yeah, it's like generally every 1 to 3 months. Mm-hmm. Yeah. Yeah. Mhm.
And where I
Right. I mean, it's a lot of diagnosis in the EMR that say just 3, right? I don't know if anyone is, the DSM is like 311 depression not specified, but it depends. It's a very strict, like 2 weeks, this, and this, and this. I mean, if you feel like you have that, then I would say you could put in, I use major depressive disorder, single, recurrent, moderate, right? I don't know if I have the time to do that kind of assessment, but if you feel like, based on your screening and the symptoms, certainly if a kid is expressing passive thought of death or suicidal thinking or, you know, isolation, I feel hopeless, my self-esteem poor, my grades have declined, like all that needs, right? There's no one says you can't use medicine for depression not specified. I do. You know, I mean, then you could, if you feel more, that you could start medicine and refer, you know. So all we do aren't diagnostic. It helps us with our clinical judgment and our, make our diagnosis. So it's the criteria. But, so I guess you have to use the tool and put it together to like kind of list it out and for how long. And if it meets criteria for major depression, then I would say you could make that diagnosis, right? And in the DSM-5. Yeah. Probably DSM-5. Helpful to have since you're seeing a lot of, or at least the 5 criteria for major depression, general anxiety. I mean, those are common, I would think, that ADHD, those kind of things. Yeah. Right. Correct. Yes. Yeah. Mhm. Yeah. Right. It's definitely a challenge because even though we have our own group of, most of my patients are seeing providers on the outside. I'm constantly having to make phone calls to connect with them. Sometimes for follow-ups, I only have 30 minutes, but I will spend most of my follow-ups with our teenager together, sometimes separate them out. When there's a safety issue, I bring them in and I really go over, like, if a kid said to me, well, I cut myself, I don't want to tell my parents. That's not okay. I have an obligation to share that with your parents. We have to talk about a safety plan, especially starting medicine. If you kind of go at it factually, sometimes in an eval, they'll say, like, I don't want my parents to know this, and I've been caught, they don't know. But when we talk about the warning on the medicines, I say to them, well, it's really important for me to tell you because they need to know a baseline of before then because there's this warning on the medicine and we need to know if it's getting worse or better. But is hard to, I don't know if I'm in, because I don't have really the best answer other than if I don't feel comfortable in the session, like if someone's not safe right in the moment, I send them to the hospital. If I have discussion with the parents, I have discussion with the parents. I think primary care, if you don't feel comfortable, like a medicine change like that, because that's, I mean, again, this is my expertise, this is what I do, then you could, to psychiatry, I think I would like to work on, if it's not happened yet, this is an ultimate goal of mine, to have some better collaboration between primary care and psychiatry, like sort of consult, you know, like a case some sort of consult where you guys could say, you know, I have this, like for that situation, right? What do I do? And then we have some sort of consult. So that's an ultimate goal of mine, because I think we need better collaboration. So I kind of with some of the primary care docs, but that would be, I think, a great way to formalize that. I know we're trying to embed specialists in primary care offices, but I think there should be a better way to provide you guys with some sort of, like, how you're in those kind of situations, and then with a process. So then here's what you should do, and then get them transferred. Okay. So let's on to anxiety. I love working with kids with anxiety. It's one of my favorite things. Just be focusing really on social anxiety, generalized anxiety, session anxiety. PTSD and OCD are totally separate issues, so I'm really not going to focus on those things, but I work with those kids as well. Here's kind of an example of really a classic, you know, 9-year-old anxious kid. So it comes in with parents, out of else at home, coming down to their bed at night, more often, complains of stomach aches, headache, going to nurse at school. Really well in school, teachers say he's quiet, but he's a behavior problem. He's well-liked, hesitant to join in. Was really anxious. Mom says Sam was never anxious until now, but then she said, well, he was a fussy baby. He clung to me and cried when she took him to preschool. He grew up. He has a time to warm up to others. He's not the most social. And medical history is good. He was by GI neuro. So really common anxiety disorders kind of start around age 6 or 12, except separation anxiety, and then phobias can occur earlier. Anxiety predicts like later in life, and also additional substance use risk and depression. It predicts later portioning. There's a genetic predisposition. You know, anxious parents have anxious kids, can see that in your office, the dynamic between them. So again, it's kind of rare, but you know, I always look for kids are I found them to be hypothyroid actually, and so I always look at like physical symptoms going on. So tools, you know, worthy to note. Again, I don't use a lot of these screening tools, but there's one that's really good, and this is Scared. And they're really good website. The American Academy of Pediatrics has a good chart of like good and reliable screening tools for spring. I think again to keep in mind, just like depression is this developmentally typical, or is this something more clinical that we need to treat? And has there been a significant stress or trauma in this kid's life? So, like, what is developmentally appropriate? Because I have parents come in a lot of times, and they're telling me things about their kid. They think he's anxious or she's anxious, and it's pretty typical. And when I educate them about that, they kind of understand. However, it becomes their separation is continuing through 2nd and 3rd grade. Okay, that's not typical anymore. School-aged kids have a lot of real-world danger. There are bad people, you know, lots of voice, right? But if that comes in pain and they can't sleep at night and they're in your bed, I see a lot of kids that, in their parents' beds, 10, 11, 12, because of their anxiety. So we have to rate what's developmentally appropriate, how long is going on, how much is it interfering with their functioning. A lot of kids have lots of pains, right? They always have a stomachache, they always have a headache, they're always going to the nurse. The nurses know these kids by name at school. They don't eat well because if they're anxious, they're either not eating well or they overeat because they're stressed out. They don't eat well, they're always having nightmares. They don't like to be away from their parents. It turns into avoidance. So avoidance of school early on turns into avoidance of school, and that becomes truant, and then it becomes a whole legal problem for the parents. Come in with lots of temper tantrums, and the parents think that they're oppositional. They're good in school all day. They hold together. They come home. They blow up and cause chaos in the house. Over time, that when you ask parents and kids are anxious, they you and they're like anxious, they start talking about all these things that they worry about, or they have fears of, or frustrated about, and are all saying like, "Oh, I'm not anxious," and then I say like, "Well, think about." Oh, I think about everything. I can't sleep at night, and they like use different words. So I try to, in my evaluation, use and terms, and all of a sudden they just start describing all this stuff that we call anxiety. They don't call it that. Again, kids will tell me all these things in their body. A lot of times, kids have been seen by GI, by cardiology, neurology, every specialty, and then they come to me, and the parents say, like, I've taken them to everybody, they say nothing's wrong. I really explain to them that anxiety is really powerful, and it can do a lot of things to the body. It can paralyze you. It can make you pass out. It can make you have a seizure-like episode. And we talk about how that's really scary, but if you're doing this to your body, and if you do have something physical, it can certainly make it worse. So it really helps them feel better when they see this, because they look, that is happening to me, and they can understand how to calm their body down when having anxiety, so that then they can show their body's reaction. By Bruce Perry, and it just really resonated with me because I talk a lot with kids about staying calm, and I think that kids come to us a lot. Parents bring kids a lot to me, and I think that for an eval for ADHD, which there's ADHD going on, but a lot of times we're not thinking about anxiety. So we all have states of alertness, arousal. So we're really calm. So when I talk with kids about it, I'll draw a thermometer. And when we're at the bottom of the thermometer and we're cool, how does that feel? Well, we're relaxed, we're calm, we can think and reflect. So in our stage, right, that's like kind of where we are now. Well, maybe I'm in the stage. But that's how it's cool, right? You're alert. You have to be that way to think, to be, in the world around you. You can still ask for help if you need it, and you can accept it. But what happens is you go up on that thermometer and you hit this point where in alarm stage, this is where kids with anxiety spend most of their time. It's like our system in our country. So they are not able to use their cognitive thinking. They are emotionally driven. And so it is very concrete. They can't see the big picture. They have more frustration, and they ask for help. What they want. This is fear. So this is when parents are like, they're in the classroom, they're hiding under the desk, they're going to the nurse's office, in their closet. And in the office, it's because they've reached terror, right? So they're in avoidance. They're having massive meltdowns. They're talking about, like, I'm going to run away. I want to hurt myself. They're in the ER. They're having panic attacks. That's the highest state of arousal. It's basically like pure emotion outburst. There is no logical thinking able to happen. Actually, parents will say to me, you know, they have great concerns because they say, like, they look like a person, they don't even remember what happened, which is pretty true. I mean, if you think about it, when we have if anyone's ever had a panic attack, you don't remember what happened because your brain takes over. You're not able to be logical at all. I think it's really important to think about this. I really love the way he talks about these different states of arousal. Kid is not doing well in school and has poor attention. I always think about anxiety in addition to ADHD. So, and similar to depression, you know, SMILE, we really want to think about psychotherapy because kids will respond really to behavioral intervention and really good skills to calm their bodies down. But the problem is, you know, there's a lack of providers, right? There's a lack of good cognitive behavioral providers. And if it's more moderate or severe, we really know medication will help them make better use of the therapy. So, I mean, we talked about medicines already, and they're really similar for the SSRIs are still the first line treatment. And pros the most evidence for treatment and generalized anxiety, and Lexapro is kind of a option. The study was one of the largest studies using Zoloft, showing that benefit was a combination of cognitive behavioral therapy and Zoloft. And then the mentioned treatment study with following that. Really, the key is early treatment is really important. They're more likely to be in remission and stay in remission. In terms of like what's approved to treat generalized anxiety in kids, you know, fluoxetine or Cymbalta is actually the only medicine with FDA approval for non-OCD anxiety in kids. And it's fine because we still know there's more research and evidence for the SSRIs, but some kids don't tolerate the SSRIs. They have side effects. Cymbalta is a good option to go to. These are had lots of studies for all different anxiety disorders and kind of give evidence to use the SSRIs. This was analysis between SSRIs and the SNRIs, which again I think is important to look at because it showed that there was a greater improvement using SSRIs in kids. And I think what interested me was that it shows that, you know, probably the reason why is because maybe the serotonin system emerges earlier than the noradrenergic system, and that's why the serotonin medicines work better. I want to talk quickly about other medicines, right? So Susie, 8 years old, comes in, she's having bad dreams, she's out of control, she's refusing to go to school, she's having outbursts, she's really overwhelmed, she's just her life, right? And she gave her one of her, a little bit of her Ativan, just a good help. And she, oh, I should not have, but I was desperate and it helped her settle down. Does anyone ever say that to them? Because several times. And I scold them. I say, don't ever do that again. And then we talk about options. What's disheartening is that this study showed that being put on more than 1 minute at a time and not SSRIs. So it's great 63% of kids were put on an SSRI alone, but 7% were put on an SSRI and another medicine, and a benzo being the most common. And we originally, and really, there's not a lot of evidence for benzos in kids. So that is not something we'd really want to go to. So clonidine are being used more increasingly. We have some approval, the longer acting for ADHD. So limited data for use of benzodiazepines. Again, my specialty, somewhat in selective cases, and so try to use ones that have mid-range and take them away when they're not necessary. Again, there's some research on other types of treatment. Yoga, mindfulness and meditation. A few minutes? Okay, I'm almost done. There's a great CD, it's called Sitting Still Like a Frog, and it comes with a book. And it's a kid's meditation CD. I absolutely love it. I don't know who uses a CD player anymore, so they might make an MP3 download. But it's like really great meditation for kids. I have sources on here for complicated health resources because parents will tell you that they give their kids other things. And here's some great, Mo is a free online workbook that you can download. Freeing a Child from Anxiety is a great workbook, and some great facts for families. Oh, sorry, I kind of passed over that. NAC is N-acetylcysteine, otherwise known as mucimist, probably, for you might be more familiar with that. But it's NAC is used for hair pulling, skin picking, hair pulling. It's a counter, actually. Oh, it's in pill form over the counter. So it's like one of really the trichotillomania. It's really one of the only evidence-based treatments for trichotillomania. The SRIs just don't work very well. Well, oh, it's N-acetylcysteine over there. You can do it over the counter. Yeah.
Have you heard of laughter yoga?
So I heard of laughter yoga. Yeah, I went to, so I'm assuming that's more than just like really breathing out, and it's
A lot of laughter, forced laughter, which increases serotonin levels. 10 minutes that'll last all day.
I actually one of and I know she's doing research on yoga right now for kids and adolescents, and I mean spend so much time, like I said, talking about the benefits of yoga. Image. I tell kids, use your phone, put an app. I mean, all the time. What? So thank you. Appreciate your time. And yeah, if anyone has questions, you can call me, email me, get in touch with me.